Mr. Chairman, ladies and gentlemen, thank you very much for organizing committee, for asking me to come and talk to you about novel approaches for robotic colorectal training. I'm a colorectal surgeon and I have interest in teaching and training. These are my disclosures. I work as a consultant for Johnson & Johnson, Medtronic, as well as Proctor for Intuitive Surgical. When you look at training landscape, it has dramatically changed in the last 2 or 3 decades, and I hope you would agree with me that this is for the better. This is a historical picture from 1970, where a surgeon, Dr. Poole in Texas, is trying to demonstrate a new technique of coronary artery bypass graft. And just by looking at this picture, I hope that you would agree with me that it seems like quite a challenge to achieve that particular goal for most of the trainees in the room. When we look at the current resources that are available for teaching and training of robotic colorectal surgery, it starts mainly through industry-funded programs. After acquisition of a system, you are put through a series of simulation training and then system-based training at one of the training centers, often referred to as a buttonology, where you learn the system, how to operate the system at its own. And within colorectal fertility, there are 2 main procedures where surgeons are more interested to gain skill acquisition. That is obviously rectal cancer surgery, and increasingly now people wish to embark on doing central venous ligation for the right colon cancer using this tool. The resources involve both animal and cadaver lab courses, which are often run by surgeons at various facilities. This often is followed by a case observation at a trainer hospital to see firsthand how surgery is undertaken. And then comes a variable number of hands-on proctorship events that are again funded by industry. But the important thing to realize is there is no formative assessment attached to any of these training modules. When you look at the need for developing curriculum, this has long been recognized even for robotic surgery. This is a paper nearly 9 years ago highlighting the fact that system training should be formally organized and should be competence-based instead of time-based. It's important to remember this when we go forward in our presentation. When you look at some of the programs that have been run, certainly in Europe, this is a group which included myself. We looked at teaching a new skill using both standardization and structured training or structured curriculum as a key factor to teach people before we could assess them. So obviously, both standardization and structure have long been recognized when you train people. We in Europe also develop a European-wide consensus of how robotic TME should be performed and taught. It had huge implication when we are teaching people certain skill sets. So for example, within a robotic TME teaching curriculum, we also standardize different operative steps. This is an XI system. This is an SI system, I beg your pardon, showing splenic flexure mobilization step by step. The important thing to recognize, obviously, is that once you train people in a standard and structured way, they are likely to learn faster and likely to reproduce the same technique faster. One of the problems we had at the start of the program was a different cultural background, the trainer, the trainees who were involved in the program being within Europe. So we decided to come up with a very standardized approach through video material to make it possible for the trainees to understand the procedure. So it become almost irrelevant which background the trainer have come from, because they are likely to train people in a very, very structured way. So with this in mind, a few years ago, we set out this curriculum within Europe through European Academy of Robotic Colorectal Surgery. A number of centers participated as a training center within the program. And the concept was very simple. The concept was that from acquisition of a robotic system here, we wanted people to become proficient at the end of the program, where they could safely perform the procedure without any patient compromise. Remember, we were not trying to produce expert based on this program. We were only trying to achieve competence. And obviously, when people do this over and over again, they are likely to become more and more proficient. So the concept was very simple, that once you have done at least 10 cases under supervision, which have been monitored using a global assessment score sheet, forms and unedited videos, you were asked to submit 2 unedited videos of robotic TME, which were assessed blindly by the faculty involved to give you accreditation. This is how people were taught, not a new concept again. We took it from laparoscopy for that matter. This is a typical breakdown of a procedure for robotic TME surgery. This is how people were taught. This is how people were formally assessed once the videos start coming in. This is an example of global assessment score sheet. This is the work done through in UK through LAPCO project, which we ran many years ago. And the idea really was to score our trainees in real time based on their performance for each module. The advantage obviously is that you can look at each module and gauge the trainees, how they are performing within this, for that matter. You also can look at individual trainee progress, so you can address the problem, in this case for trainee D, rather than leaving it too late. These are the number breakdown. To date, there are over 150 surgeons who participated in this program, 90 cities, 23 countries. It started as a European program, but then certain other countries and colleagues got involved. We had groups from South Africa, Israel, India, and in Qatar who participated in this program too. Up to date, 80 delegates have passed the assessment process, and they are embarked on their individual unsupervised practice following the accreditation process. This is the data. This is a study which is currently in press, where we looked at the first 26 centers who participated in the program, who were taught in a structured way using this curriculum. We asked them to collect data following their sign-off process, which means once they were sort of deemed accredited through the program and embark on individual practice, we asked them to submit data and collect data for that. And then as a control group, we asked 6 or 7 of our proctors going around teaching to provide data to do the comparative analysis. These are the numbers breakdown. You're looking at 323 cases for those 26 trainees, which were done under supervision. Once they graduated the program, they performed 626 cases independently, and 180 cases from the proctor group were also taken as a comparison. You could see the only difference obviously here is that more rectal cancers and more cancers itself were performed by the proctors, as you would expect. These are the results of those numbers. The only difference obviously is operating time, faster in favor of trainer or proctors. Estimated blood loss also significant statistically, but not clinically, 30 ml versus 50 ml, and length of stay is a day shorter in a robotic group for the proctors. But the rest of the clinical outcome, including R1 dissection rate, lymph node yield, anastomotic leak, and mortality, are very, very similar between 3 groups compared. We took out rectal cancers separately to assess if there was a problem within rectal cancer surgery rather than comparing the whole group. And you could see that there is no comparison seen in terms of clinical outcome between 3 groups, even when you look at rectal cancer as a subgroup analysis. By doing univariate multivariate analysis, a role of surgeons was not important in clinical outcome for Clivian Dendo classification complication 1 to 4. The only thing that contributed to that is obviously a rectal dissection, which we all know is more challenging than colon dissection. So conclusion from this study obviously is that EARC's structured training pathway led to a very safe training program where the clinical outcome was comparable between the trainer and the trainees, minimizing the risk to the patient who are operated on. Well, we spoke about evolution generally, but there is also an evolution in colorectal training for the better. Showed you this picture earlier on. Now, landscape is changing, and thanks to minimally invasive surgery, it is becoming more possible in the current climate of people not being able to travel for that matter. This is going to become more and more important. This is a colleague of mine in London. Some of you might know his face. He's trying to do a remote proctoring to a surgeon based in Athens, taking her through a robotic right hemicolectomy.
Branch the middle colic in there, and there might also be a vein a bit further lateral, but that's okay. You can just take them where they come. So if you go just straight up on the peritoneum, and then find the vessels and take them individually. Or you can go. Huh? That's something there, yes. So that's probably part of the middle colic, but. You know, don't be too radical here because it's a sequel cancer. So just go across, find the vessels, take them individually.
So you could see that more and more remote proctoring might play an important role in teaching people. This is 5G technology, you know, based on, you're not only able to just do telestration based on your guidance on the screen. Increasingly now with 5G technology, you can almost have a second console in a remote setup where you could contribute actually hands-on without having the need to travel. This is the first images coming out of China for that, for example, where they are demonstrating 5G technology and remote access. Very little delay in actual hand movement. So this would play a much bigger and a much wider role, in my view, with the time to come, because people would have access to this technology and they would find it safe to teach and train from a distance. So in conclusion, Mr. Chairman, ladies and gentlemen, I believe that only through teaching and training, we can bridge the skill gap that exists currently in robotic colorectal training. Standardization of operative technique, in my view, underpinned by formative assessment of any skill that we teach, is a key for any training program. And I think this is hugely important to remember when we are teaching and training our junior colleagues. I believe simulation and remote training input would play a much larger role as the technology would improve and evolve. But the important thing to remember is that the gains that we are asked to demonstrate when you compare robotic surgery with laparoscopy for that matter, they are marginal. But to demonstrate those marginal gain, you have to do lots and lots of purposeful practice that can only come through structured training and a standardized approach. I'm really grateful for the kind invitation to come and speak to you, and I'm happy to take any questions if they are there for me. Thank you very much.